Hi, everyone. My name is Yurisa. I am currently working as a clinical research fellow. I took the PLAB 2 examination last year in June, and I passed first time round. I didn't attend any courses. I basically just practiced with friends, colleagues, and that was enough. So we basically are trying to provide free PLAB 2 practice and help, because I really think that it's quite an easy exam to get through with the correct guidance and support. So you don't need to really break the bank and enroll for outrageously expensive courses, but rather try and find free courses like these. Okay, back to you, Nat.
Great. My computer is a little slow today, I'm sorry. There we go. Right, so our aims today are to give you tips and tricks for the PLAB. The main point is to allow for plenty of practice. In terms of housekeeping, any burning questions are welcome. There will be a Q&A at the end, and you will have a signed certificate of attendance on completion of feedback. We are recording this part. We won't be recording your practice, but we're recording this part. So keep that in mind if you want to unmute yourselves or if you'd rather post in the chat. And we're going to post a link to the feedback in a minute, just in case any of you need to leave early, because we're aware that this is really late for a lot of you. I'm not sure how to delete that line, I'm afraid. We're going to give you some background to the PLAB, which will be really, really short. Then some tips and tricks, which will be generalized, and then Yurisa will go over station-specific tips. Then we're going to do lots and lots of practice, mainly of the communication stations, because I'm sure that lots of you know how to examine people and know how to do the clinical procedures. And then we'll go through a summary at the end. In terms of background, the PLAB is the Professional and Linguistic Assessments Board test, which many of you know. It's for doctors who have graduated outside of the UK, the European Economic Area, or Switzerland, who are looking to practice in the UK. It's a standardization exam, meaning that they're just trying to check that your knowledge is equivalent to that of an F2 who graduated in the UK. There are 20 stations traditionally, 2 of which are rest stations. Each station is about 8 minutes with 90 seconds reading between each one. I've been trying to figure out exactly what's been happening from COVID. On one of the websites that offers a course that's about £300, they say that there are going to be 15 stations, 3 of which are rest stations, but I can't clarify that anywhere else. So take that with a pinch of salt. In terms of marking, they're looking at these 3 main domains. So data gathering, technical and assessment skills, your clinical management skills, and your interpersonal skills. And there are lots and lots of ways in which they can assess that. In terms of clinical examination, there is a simulated patient, which may be an actor or an anatomical model. There are basic examinations, and this does include genital exams. They'll also be checking that you can use basic equipment, and the exams include the mental state exam. In terms of anatomical models, this is straight off the GMC website. They've said don't speak to the model because you won't get marks for doing that. And only if the instructions tell you to, you should tell the examiner what you're doing. So this can be a little awkward if you're used to saying, and I'm looking at the hands for this, or I'm looking at the hands for that. Therefore, what I do to get around this is I tend to talk to the patient and tell them what I'm doing. And that way the examiner can not only see what I'm doing, but they can also hear it. Just in case they miss something that you're doing, you'll get the marks. And obviously don't perform any actions on a model that would be unsafe or painful. These are some of the many practical skills that they can test you on. Feel free to take a screenshot. This is also on the website, and this will also be included in the YouTube video, so I'm not going to go through them. In terms of interpersonal skills, there are a lot, and this is where most people tend to struggle. So this is what we want to focus on. For more information, you can search for the PLAB blueprint on the GMC website. This on the right is a screenshot of what it looks like. So it pretty much tells you everything that they can test you on. It is many, many pages long, but it's really, really useful to have a flick through because then you can see, oh, these are the things that they can ask me about. I can brush up on them. So we're going to go through some general tips and tricks and then some station-specific ones that Eurissa will tell you about. So in general, these are really useful resources. Please screenshot this, or I'll give you a minute to write them down. Again, it will be on the YouTube video, and we will post the links to each of these in the chat. Pretty good to go through these. And then OSCE Stop and OSCE Aid also have a lot on communication stations, which are pretty good. So BMJ, Aurora, Geeky Medics, GMC, OSCE Stop, OSCE Aid, and Oxford Medical Education. So in terms of general tips, pay attention to what the scenario is. Where are you? Are you in A&E? Are you on GP? Are you on the ward? This changes what is available to you and what your next steps would be. So for example, in A&E, you're going to talk about whether or not this patient needs to be admitted, whereas on GP, you'll talk about the next steps. Can this patient go home? Do you need to advise them to go into A&E? Is this someone that you'll just need to follow up? On the ward, does this mean that you're no longer going to discharge this patient? Do you need some extra help, etc.? Have a think about what it is they want you to do. Do they want you to examine? Do they want you to explain? This can change because, for example, a data interpretation station can include some explaining in it. Or a data interpretation station may specifically say that they don't want you to actually take a history at all. And lots of people can be thrown by this. You already know the medicine. This is stuff that you guys do day in and day out. So think of it as just another day at work. In terms of keeping it real, you can say that you're going to look something up or discuss it with a senior. Remember, they're only assessing your knowledge as an F2. They want to make sure that you're safe and that you're appropriate, that you're not doing too much work that's beyond your knowledge or abilities, but that you're also making sure that your patients are well cared for. So always make sure that you're going to safety net the patient. There's always some kind of follow-up to arrange, whether that's an appointment or investigations or referral, and make sure you welcome further questions from the patient, even if you're not sure you can answer them. The main thing that we're going to be focusing on today is the patient-centered approach to things, so showing your interpersonal skills. You might be asked to explain treatment options, but how much does the patient actually want to know? And if you do suggest treatment, ask how they feel about it. The patient might lead you down another path completely. Active listening, so reflect back what they're telling you. Make sure you're empathetic. And keep in mind that the patient has a script. They know that you've only got 8 minutes to get to the end of this. So don't start going off on a tangent with specific questions. Think about whether or not the patient is trying to lead you somewhere. So in terms of stock phrases, it's nice to have something to say when things are a bit tricky or awkward, but make sure you're actually listening and you're not just repeating back things that you've learned. Get an idea of some things that you can say, especially in these difficult situations, but don't just say them for no reason. Make sure you're saying them for a good reason. Feel free to share yours. These are some that we came up with. So if you want to elicit concern from a patient, you can just ask them, is there anything that you were particularly worried about? Was there something about this which concerned you? You seem worried about something. Why is that? Or if they've mentioned it, reflect it back to them. You spoke about the endoscopy. You seem worried about it. Why is that? You asked about discharge plan. Was there something that worried you? Sorry. And then the very generic, do you have any other questions for me? In terms of showing empathy, phrases that we've got are, I'm sorry, this sounds really difficult. It sounds like that must have been really hard to go through. Try to avoid saying, I understand how you feel, because the fact is that you genuinely don't, because you've not been through it. And sometimes patients can find that quite off-putting. In terms of improving communication, so if you need further information and the patient's gone off on a tangent and you're really sure that they're leading you off the track and you need to get them back onto the right track, tips and tricks are things like, it's really important that I get more information about whatever it is. Mentioning, does what I'm saying make sense so far? Can you explain it back to me so I can make sure I've been clear, rather than almost testing the patient? Or I need to ask some more personal questions. I hope that's okay. So Eurissa's going to talk to you about station-specific questions. So I'm going to stop sharing my screen and allow her to share her screen.
Great, thanks, Nat. Just getting slides up. I'm actually just going to pause for a second just and make you host now, Natalie, so you can admit. Can you all hear me? If you can just put in the chat if you can hear me. Okay. Okay, and just opening the slides. So the next section will be discussing. If you're all able to see the slides, just give me a thumbs up or something in the chat if you can see the slides. Okay, great. So the next section is a few tips and tricks, which is very station specific. So in terms of the station types we'll be covering, we'll be going through, let me just make this big screen, examination station, data interpretation, clinical skills station, and communication stations, which we think are very important. In terms of the examination, generally this won't be performed on an actual person, but rather an anatomical model. But you should be careful and always treat the anatomical model as you would a patient. As Natalie has said, try not to speak to the model. As the GMC have said, you won't gain any extra marks by doing this. And try and verbalize, if possible, what you're doing as you go along. And also just be mindful of what the instructions say. So if the instructions say, verbalize your examination as you go along, or if the instructions say, speak to the mannequin as if it was a patient, then just go according to what the instructions say outside the station. Again, be systematic. So the examiners just want to see that you're a safe doctor, and they also just want to make sure that you're systematic, you follow through, and you don't really forget any of the important steps. So something I used in my exam was just the ABCDE approach, especially for simulated emergency scenarios. So for example, if a patient was involved in a car accident, a quick and easy way to do the primary assessment would just use the ATE. In terms of examination, I found that a lot of people who are doing the PLAB exams, they focus a lot on consent and spend maybe a minute on consent. And I think this really puts you at a disadvantage. Your consent needs to be clear and concise. So something like, hi, Mrs. X, I am so-and-so. I would like to perform this examination on you for X, Y, and Z reason. Would this be okay with you? Don't spend a long time on it. It needs to be quick. And then also just ensure that the patient is comfortable throughout. So you could say something like, please let me know if you are uncomfortable at any point. And if you are uncomfortable, let me know and I will stop the examination. And then also, before you present your findings to the examiner, take a deep breath, compose yourself, and think about the way you want to relay your differentials and your main diagnosis. So try not to be haphazard. Again, be systematic and find your style. So all of you are doctors already, so you should have a style of how you present things on ward rounds. Just try and find a systematic approach. And then importantly, try and get to the management stage. So then you know that you've covered everything, and mention a few of the management points. Again, try and make sure it's patient-centered and you keep the scenario at the back of your mind. In terms of data interpretation, this could be something that can be incorporated into stations, or it could be something that could stand as its own station. So for example, you could get, as a scenario, you could get a list of blood results. So I'm going to use this example of blood results showing a microcytic anemia with low iron stores. And maybe you're just told you're here to see Mrs. X, who has these blood results. And then basically in the 90 seconds outside the station, you'll have to yourself glean from the blood results that there's a microcytic anemia with low iron stores. And then when you enter the station, you need to start with a quick history. So this is going to score you points for gathering information. So you need to be focused here and concise. So think about relating the blood results to the types of questions you'll ask on history. So for example, you'll be asking about symptoms of anemia, which we all know. Um, and also to show your interpersonal skills, even in the data gathering section, you'll ask questions like if they're really short of breath because of the anemia, or if they're really tired, ask about their daily function and the impact on work and life. And then other questions you could ask are to elicit underlying causes. So for example, you can look for any symptoms of cancer, but remember, don't mention cancer because you don't really want to alarm the patient. So you could ask things like, have you noticed any loss of weight, or any loss of appetite? And then another important thing to note is if the patient is female and they have anemia, always ask about the menstrual history, because usually this is one of the commonest causes. Um, Again, ask about diet, and then finally family history. So on family history, you could say, you could ask something like, are there any serious conditions in your family? You don't have to specifically ask about cancer, because again, you don't want to alarm the patient. Or you could make it a general question like, are there any serious conditions in your family? For example, cancer. So it's there's less focus on cancer, which can be quite scary for patients. And then when you're explaining the blood results to the patient, don't use any jargon. And then again, use the information you've gathered from the data gathering section to try and put the results into context for the patient, and then also to come up with a management plan. So for example, you could say something like, Mrs. X, these results indicate that the cause of your tiredness and shortness of breath, or whatever other symptoms they have, is something called anemia, which means that you have lower numbers of red blood cells in your body due to a lack of iron. So try put it all together, because this really shows the examiner that you've really understood the scenario and you've put together what the patient has given you. And then you can also go one step further and say this might be because you have really heavy periods, and you could try and normalize it, and so that the patient doesn't feel really anxious, by saying something like, this is a common problem in a female at your age, and the good news is that it's treatable, and then discuss management plans. So for example, iron. In terms of clinical skills, like Natalie has mentioned, there are many ways to assess this. So you could be asked to demonstrate a skill on a mannequin, or teach a student and or colleague a skill. Again, be systematic. So go through systematically, and then keep checking the understanding of, for example, if you're teaching a colleague, keep checking in and making sure that they've understood what you've said. And a good way of checking that whether someone has understood what you've said, whether it be a patient or a colleague you're teaching, is to ask them to repeat in their own words their understanding of what you've told them. And I think that's something that's useful in practice and also in exam situations. In terms of communication stations, um, as a general principle, you should try follow the principle of first gathering information by using initially open-ended questions, then moving to more specific or close-ended questions as you fully understand what the scenario is actually entailing. And then again, avoid jargon. So avoid complicated medical technical terms. Keep everything patient-centered. So keep checking in with the patient, checking in their understanding, and checking in whether this is a treatment option they would actually like, or their opinions of the treatment that you've suggested. Also, try and think laterally about management options. It's not all about medication. So we will be discussing a scenario soon. Um, okay, I'll talk about that when we come to the scenario. So in terms of communication stations, the types of stations you'd be expected to undertake would be a history-taking station, breaking bad news, an approach to the angry or upset patient or relative, explaining a procedure, either to a patient or a colleague, performing a handover or referral, counseling on dietary or lifestyle advice, And finally, having difficult conversations. In terms of the history station, like I've mentioned before, start with open-ended questions and then move on to more closed-ended questions as you understand what's as your understanding of the patient's presentation and what the differential diagnosis could be. And remember, as Natalie has said, that these actors have a script. So they're already briefed on what questions they what answers they should be providing. So if they're trying to lead you down a different track or different train of thought, try and think about why they would be mentioning something to you, and try and divert your train of thought as well, and try and think about what they're saying. And it's important to also note that the examiners know you're short of time and they know you're stressed. So yeah. Take one question at a time and try not to interrupt the patient. So let them say everything they need to say. Even if you feel like you're not going to finish the station, rather try and show that you're listening to the patient and score marks on interpersonal skills than trying to rush through and scoring 0 for that as a result. It's also important to always ask about red flag symptoms and exploding symptoms. I'll explain this on the next slide. And then also to signpost important points, summarize and create a plan with the patient. And finally, something I find very important for any patient consultation is safety netting. So ensuring there's some sort of follow-up plan that you and the patient understand. So a brief note on exploding symptoms. So it's basically just, for example, if you're looking at abdominal symptoms and you want to look at diarrhea specifically, if you thinking if the patient's presenting with diarrhea, then you ask questions like how much, how often, the consistency, color and contents. This is just an example from OSCE Stop. So the next type of station is a breaking bad news station. Something I really like is the spikes protocol. This is a good framework. Again, this is just a tool and not a rule. So S stands for setting. So you're looking at whether the room is well set up. I would say for the exam, I avoided moving any furniture around. I think I shifted my chair slightly and then I just sat down and started. So I don't think you need to worry about the setting too much. But if you see tissues in the station, or if you see props, use them. If you see a glass of water, you can hand it to the patient. P for perception. So you need to glean what the patient knows so far. So just check in about the understanding of what's gone on until this point. And then I is the invitation. So you need to ask the question of, would they like to know information, and what would they like to know? You also need to find out whether they'd like anyone here with them when you give them this really important news. And then the K stands for knowledge. So you need to remember to chunk and check here. So you give a little bits of information and then ask them whether this makes sense so far. And then, so you could say something like, so as you know, your results have not been showing X, Y, and Z, and we did a test which showed this, and you can have pauses in between and keep asking, does this make sense so far? Give them a moment if you see that they have become emotional, and keep asking whether you should keep on going. And you could also even ask, would you like me to pause and we could bring someone in, who would like to be, someone who you would like to join us to receive the rest of the information. Yeah. In terms of the E, it stands for emotions and empathy. So this is demonstrated throughout when you're breaking the bad news. And then finally, S is the summary, and importantly, the plan. So here it's important to make sure that they have understood everything you've said. So you could ask them to repeat back their understanding of what's gone on, and then make a plan of when you'll follow up with them. And if they think of any other questions, find a means for them to communicate with you. So the next type of station you could have is the angry or upset patient. There can be a lot of crossover of the station with the Breaking Bad news station. So it's important, again, like we've done for the other stations, to collect data. So it's a similar type of setup to the Breaking Bad news station. And then the management of this scenario is to acknowledge when the patient is angry or upset and apologize, and also allow the patient to express themselves. And then, importantly, something uh, which evidences active listening is reflecting and acknowledging their feelings. So if someone says they're really frustrated, you could say something like, I can hear that you're really frustrated and it's understandable in your situation. So that shows that you've listened actively, and it shows that you're acknowledging what they've felt. It's also important to maintain eye contact, and don't be afraid to say sorry. So apologize, even if it isn't a mistake you've made. Um, it's always best just to say sorry on behalf of your team. And then in terms of ACT, you need to come up with a plan of what you can do to prevent this issue in the future, and ensure that the patient understands that you're here for them and you're trying to prevent this type of problem from happening again. And then finally, so you need to make sure that you and the patient are on the same page, patient or relative, and make sure that they agree with your final plan. So other tips, try not to argue or disagree with the patient. I mean, you can disagree with them, but don't try and argue with them. Agree to disagree, basically. And don't try and deflect. The whole point is that you're working in a team, so it doesn't matter who has made the mistake. So don't blame anyone or say, I wasn't there, it wasn't me. You could just say that on behalf of the team, you're really sorry and you hope that you can work together to prevent this from happening in the future. Also, offer to allow the patient or relative to speak to senior colleagues, set up meetings if this is something they would like, and also work on preventing this from happening again, and explain a plan of how you aim to prevent this from happening in the future. Also direct them to PALS, patient advisory liaison services, if I'm not mistaken. And then also suggest that you fill out incident forms, which is also a really important tool. So quite a different example. So I just want all of you to think about how you would answer this scenario. You are an SHO on the neuro ward, and Mr. Josephs has come in with his second unprovoked seizure. He works for Transport for London as a bus driver. So please counsel him on driving rules. So if anyone has any ideas they want to put in the chat, we won't spend too long on this, but I just want to see how many of you would be comfortable with a scenario like this. Anyone, or I'll just move on. So this is quite a tricky scenario, but you do need to know about the DVLA driving rules. So this is what I assume that most people would be stumped. But even if you're stumped in the exam, the important point is that you can still get so many of the marks for data gathering and for demonstrating interpersonal skills and some of the management as well. So you just start the scenario by gathering data. So asking open-ended questions, moving to closed-ended questions. So you need to ask the patient to describe the event, were they witnesses, just go through your regular history, and then gain an understanding of the patient's job, what type of driving they do, did the event happen while they were driving, and then also give them information. I mean, you don't need to have read the specific UK laws to understand that if a patient has had 2 seizures, they, it's unlikely they're going to be allowed to be driving. But it's good to familiarize yourself. On the next slide, we have a list of the DVLA rules. And then, yeah, so I think we'll move on to, oh yeah, and finally, try and problem solve or come up with a management plan. So even if you have no idea about the UK driving rules, or you've forgotten them or anything for some reason, you could come up with an alternate plan, like you could speak to your HR or occupational health, and maybe we could get you a job in admin or something else, because it sounds like it's really unsafe for you to be driving at the moment. So where you'd actually get specific information on how to answer this scenario is something called the Driver and Vehicle Licensing Agency, and they have very specific regulations on for specific conditions. So for example, this is for a bus, coach, or lorry license. If you've had more than one seizure, you should not be driving, and you need to go onto their website, and the patient needs to go onto the website and actually submit all this information. So you as the doctor need to advise them that they shouldn't be driving, and then maybe come up with alternative plans of other work they could do in the meantime. So you could actually just search, the Royal College of Emergency Medicine has a good summary of all the DVLA advice for the most important conditions. So I think some of the ones you should look at are epilepsy, syncope, MI, and a recent stroke. Yeah. Other UK specific things that you might not have heard of would be basic knowledge on laws around sectioning a patient. So in terms of the Mental Health Care Act, and then also looking at the Mental Capacity Act. So the next type of station could be explaining a procedure to a patient or medical student. Again, avoid jargon, be systematic, and try and cover the indication, the process, so what actually goes on with the procedure, the risks, benefits, preparation, aftercare, and any alternative. And then again, also find out whether this is actually something the patient, if you're explaining to a patient, if it's something they want to consider or if they would like to know about alternate options. In terms of a referral, so you could be in a station where they ask you to refer or hand something over to another colleague. SBAR is a nice way to do this. So it just stands for Situation, Background, Assessment, and Recommendation. It's quite a nice tool to summarize everything. Again, it's just a tool and not a rule. For exam purposes, I'd say you should just stick to it. So in terms of situation, you describe what's happened, then background, you give a background. So for example, the patient is known with XYZ. Okay, so I'll just do an example quickly. So situation, I am Urisa, the nurse on the ward. I'm calling about this patient because of X, Y, and Z. He is known with a past medical history of X, Y, and Z. I think my top diagnosis is this. I have already done this, this, and this. Please, may you come down and see this patient? And is there anything else you think I've missed out or anything else I should do in the meantime? That's an example of a brief SBAR handover, sorry. So the key information to include your name, grade, and department, the reason for calling, a very short patient summary and management, and then also just make sure you ask who you're speaking to on the other end of the call. And then if there's anything else they'd like you to add to the management. In terms of counseling stations, so generally you need to elicit the reason for the patient's current behavior. So for example, if a patient is smoking, you need to ask why they enjoy smoking, and then move on to looking at eliciting their readiness to change. So this is the, I've forgotten what it's called now. well, the 5 stages of motivational interviewing basically, and where a patient could be at. So they could be pre-contemplation, contemplation, preparation, action, or maintenance. You don't have to follow this. It's just something that's nice to understand where the patient is um, in their ability to change this habit. So you could ask a question like, have you ever tried to quit smoking before? Um, what is motivating you to stop smoking? What did you try? What worked and what didn't work? And what ideas do they have to try this time round? And again, keep it patient centered. So keep asking what they would like to try, what information they would want. Would they like you to go through the pros and cons of smoking, as an example? And then think widely about the support you could access. So medical help, multidisciplinary team, specialists, support groups, and then come up with a plan together with the patient. So adding on to the smoking cessation approach, um, generally you could use the 5 A's approach. So the 5 A's are ask, assess, advise, and assist. So ask, just data gathering again. Assess, so assess their readiness to quit. Just basically take a quick history. And then advise, try and tailor the advice to the patient's questions, and then keep checking their understanding. In terms of assist, I think this is quite useful, the STAR framework. So set a quit date with the patient and ask them to tell their family, colleagues, friends about the quit date, because they're more likely to stick to this date if others know about it, and also ask for their support. And then anticipate challenges and brainstorm ways to overcome them even before um, they occur. And then R, remove any tobacco products or areas which the patient used to smoke in. And then finally, the last A is arrange, follow up, and safety net. So I think we've basically gone through this. And we will have a scenario later on about this. So in terms of counseling, another station which you could get is counseling on a flu vaccine. So you need to look at the patient's concerns about receiving a vaccine or any misconceptions they could have. And then be mindful of what you say. So remember that patients are entitled to their own opinion and you can't impose your opinion on them. So for example, if a patient believes that the vaccine is related to autism, you are not there to try and change their opinion. They have that opinion and it's obviously a fixed opinion. You could just counsel them on or equip them with the information that you have, and ultimately it's still their decision. And then you can also look at the pros and cons if this is something they would like to know about. But also important when counseling on the flu vaccine, ensure that they don't have an egg allergy, because this is an absolute contraindication. And it is important, I mean, it is safe in pregnancy and in children 6 months of age and older. And then come up with a plan together with the patient. In terms of difficult discussions, examples of stations could be end of life care or palliative care, organ donation, refusing life-saving treatments. So in this scenario, you could just assess a patient's capacity, speaking to a colleague about inappropriate behavior in the workplace, discharge against medical advice. Again, you'd probably assess capacity. If a family member asks you for information regarding your patient, then this would be assessing confidentiality. And then consent or capacity in a child less than 16 years old. And then you'd need to look up Gillick competence and the Fraser guidelines. And then finally, non-accidental injury. So for this, it could be a scenario like a toddler keeps on coming into the A&E with bruises. Please speak to the mother and discuss the mother's concerns. And then you need to maybe think about non-accidental injury here. in terms of palliative care, in this kind of scenario, you need to always remember about what the primary diagnosis is. So what condition does this patient have, and whereabout are they in the palliative care journey? How much do they already know? Do they know that they're under palliative care? What is their current management plan? And then again, when you're formulating your management, look at the biopsychosocial approach. So look at the symptoms, their feelings, involve the family, and also be mindful of religious beliefs. And then again, just elicit their fears, ideas, concerns, and expectations. That you can use that. It's a mnemonic called FICE, which is the fears, ideas, concerns, and expectations. And then again, involve the multidisciplinary team and the family. And you can check whether there are already plans in place, like an advanced directive or a DNAR. Okay, I think I've gone a bit over, but we're now going to the practice session.